السلام عليكم. أنا اسمي عاصم الشريف، وطبيب أورام في مستشفى هناو، مستشفى تعليمي لجامعة فرانكفورت. آم، وكنت شغال في مصر طبيب أورام في آه، مستشفى أيادي المستقبل، وفي مستشفى الأباري تبع وزارة الصحة في اسكندرية. والنهاردة هنتكلم عن موضوع كبير، موضوع ضخم، موضوع كولون كانسر. The topic is really like a big topic, and I'm gonna concentrate on the prophylaxis, on the screening measures, and the treatment of early stages. So the epidemiology, according to GloboCan statistics for 2020, colon cancer is the third most common cancer worldwide. In females, comes breast cancer on the top of the list, followed by lung cancer. In males, comes lung cancer on the top of the list, followed by prostate cancer, and then colon cancer. Males have a relatively higher risk of colon cancer than females, and according to the German statistics, 90% of the first diagnosed patients are above 55 years old. So a very important like factor in determining the treatment and determining also the prognosis is the sidedness in colon cancer. We could divide the sidedness to right side and left side. The splenic flexure is the separating line between both sides anatomically, and the right side have a less incidence. It comes like relatively more for women. It is mostly diagnosed in an advanced stage, and it have a worse prognosis. And in the first line of therapy, in metastatic colon carcinoma, we give no anti-EGFR. So it also determines the treatment. In the lung colon cancer, it's more common, and like 75 to 80% of the colon cancer are left colon cancer. And it is more common for men. We could diagnose it in earlier stages, and it is mostly chromosomal unstable, which also a good factor for better prognosis, and it have a more overall survival. Sorry. The risk factors and risk groups for colon cancer. So we have the risk factors are like genetic. There are genetic factors, genetic predisposition, colorectal adenomas, chronic inflammatory bowel disease, high alcohol consumption and smoking. It also affects or affect the susceptibility of a human being to colon cancer. Also, how the person eats could affect the susceptibility to colon cancer. And yeah, it's been proven that the low fiber, high fat diet with high proportion of processed sausages and low proportion of vegetable make the person more susceptible to colon cancer. Lifestyle, obesity, and sedentary lifestyle is also a risk factor. The genetic factors, they are like only 3% of the cases. There is hereditary non-polyposis colorectal cancer, the HNPCC or Lynch syndrome. They are mostly microsatellite unstable and almost never BRAF mutated. That's also important for the therapy. And there's also the familial adenomatous polyposis or the Gardner syndrome, and those hereditary diseases make the patient more susceptible to to colon cancer, and it have its own like follow-up and screening measures, as we will say further. So the pathogenesis, how could the cells and how could an adenome or a hyperplastic cell appear and then transform to a malignant tumor? So there are the main factors or the main genes or the main alterations are the APC, adenomatosis polyposis col gene, and the MMR gene, mismatch repair gene. That's mostly by microsatellite instability and by HNPCC, the KRAS oncogene, and DCC or deleted in colon cancer gene, and as we all know, the TP53 tumor suppressor gene and the NM23 metastatic suppressor gene. Alterations in those genes makes a cascade for the cells so that they first make a hyperplastic condition, and then adenome, a precancerous lesion, and then a cancerous lesion, and then metastatic lesion. Sorry. Histopathological subtypes. So the mostly common histopathological subtype of colon carcinoma or colon cancer are adenocarcinoma. Adenocarcinoma make about 90% of colorectal carcinomas, and the most common adenomas from the histopathological type are the tubular, and then the tubulovillous, and then at last come the villous. And we should be thankful that the tubular, the most common is, because the tubular are the most evil. Also, they are the most risky to convert or to convert into a malignant tumor. The risks of malignant transformation of adenoma depends on its size. So we say adenomas more than 1 centimeter are more susceptible or more risky to transform to malignancy. Degree of dysplasia, dysplastic dysplastic adenomas are more risky, and the histopathological type, whether villous, tubulovillous, and tubular, as we already said, the more villous, the more evil. Number of the adenomas. So when we find that the patient more than 3 adenomas in the coloscopy, that the patient have more than 3 adenomas in the coloscopy, that should be also alarming for us. And sure, the age of the patient, as we already said, above 50 is already significant. Tumor genesis, mainly an adenocarcinoma sequence, as we already said in the last slide. And there's also another pathway called the myxotype or the serrated carcinogenesis pathway. The other histopathological subtypes in colon cancer are mucinous adenocarcinoma. That's the second most common, and that shows like 5 to 10% of the colon cancer. Signet-ring cell cancer is less than 1%, more commonly presenting with peritoneal carcinoma and worse prognosis. Small cell carcinomas, squamous cell carcinomas, undifferentiated carcinomas, adenosquamous carcinomas are a rarity, and neuroendocrine carcinomas. Also important for the determination of the therapy and the prognosis are the CMS classification. That's one of the most actual or the most new classification to the or subclassification of the colon cancer. That's a molecular subclassification. Depending on many factors, mainly in the immune histochemistry of the tumor. So the microsatellite instable immune, that's the CMS1. That's an immune activated tumor, and that occurs mostly on the right side of the colon. The CMS2, canonical, also called the canonical subtype, that's the most common one, and it's not immune activated, it's immune desert. It has a high EGFR, and it's mostly occurring in the left side. CMS3, the metabolic subtype, that's the least common type, and also it's not an immune activated. It has a RAS mutation, and it's mostly occurring on the right side, and the most common is the mesenchymal subtype. It's characterized by the angiogenesis and TGF beta receptors. And stromal infiltration, it occurs in both sides, and it have a relatively less overall survival. So the symptoms of colon cancer, we all know the symptoms, and unfortunately, colon cancers are first symptomatic in the most of cases when it's a little bit too late. Changes in bowel movements, constipation or diarrhea or paradox diarrhea, hematochezia, so bloody stool, flatulation, sometimes with stool incontinence, or an unwanted friend with the flatulation, as we call in Germany. B symptoms are also important in most of the tumors. We should ask the patient, as we are taking history, about night sweats, night fever, loss of weight, and loss of appetite. Symptoms of anemia, like the patient could feel easily exhausted and could have like dyspnea and also tachycardia. Abdominal pain or a palpable mass in the examination, ileus is a late symptom, and actually colon cancers could cause ileus in more than one way. They could mainly obstruct the colon, or they could, through peritoneal carcinoma, make a stenosis from outside of the colon. Also, in the case of peritoneal carcinosis, I have already seen a patient with a creatinine of 20 in the emergency room. He was a 45-year-old patient, and he had a creatinine of 20. We have made a sonography of the abdomen, and we have seen like post-renal genesis. There was an obstruction in the ureter, both sides of the kidney, and that patient was known of colon cancer. He would have been transferred to the urology department for double G catheter, double J catheter, sorry. Jaundice could also appear by peritoneal carcinosis, when the peritoneal carcinosis also obstruct the hepatic or the hepatic ways or the and make an extrahepatic cholestasis. This part is maybe more interesting for gastroenterologists. We are mainly talking now about the early diagnosis and screening measures of colorectal carcinomas. So we all know the gold standard of colorectal carcinoma screening is the coloscopy or colonoscopy, but the interesting question is when we make a coloscopy, or for which patients we make coloscopy. So we have two groups of patients. First group is the non-risk group. Those are the patients who are, if they are men, they should be above 50. If they are women, they should be above 55. That's the age limit in Germany. Actually, in Austria and in Switzerland and in America, the age limit is a little bit lower. So we are talking about men above 45 years old in Austria and in America, and women about 50 or above 50 years old of age. Given that those patients have no history of colon cancer or HNPCC or FAP. What if the patient refuses to make a coloscopy? We could offer a sigmoidoscopy in 5 years rate, every 5 years. And what if the patient refuses? We could offer an IFOBT test like the immunological fecal occult blood test. And when the patient refuses, he should be examined, per rectal examination annually. Sorry. So the people at risk, or the risk patients, the other group. Risk patients are patients with first-degree relative with colorectal cancer, or first-degree relative with adenoma before the age of 50. Ideally, the patient should receive a coloscopy 10 years before the onset of cancer in the index patient. So if you're talking about a son of a patient with colorectal cancer who was first diagnosed at the age of 60, so he should get his coloscopy at the age of 50, but not later than 40 to 45. So he should get a little bit earlier, should get a coloscopy. So if you're talking about a patient with 80 years old, so his son should get a coloscopy between the age of 40 to 45. The first-degree relatives of patients with colorectal cancer with microsatellite stable tumor. As we would say in the upcoming slides, the microsatellite stability is actually bad prognosis factor. It's unfavorable. So the patients with microsatellite stable tumors are having worse prognosis, and therefore their relatives should be intensive, should be examined more intensively as the patient with other tumors. There's also the Amsterdam 2 criteria to determine the patient with or the relatives of the patients with microsatellite stability. That tells us that when the patient or when someone have 3 affected family members in 2 generations and 1 affected person younger as 50 years old, indicated FFP is excluded, he should receive a coloscopy from the year of 25, from the age of 25 years old, and re-evaluation every 3 to 5 years. The genetic predisposition have individual prevention guidelines. We have no space to talk about here now. And in patients with ulcerative colitis, there's also individual guidelines. When they occur to have low-grade intraepithelial neoplasy, they should get a coloscopy every 3 to 6 months. And when they occur to have a high-grade intraepithelial neoplasy, they should consider a proctocolectomy. So we have to be I would say more aggressive with the patients with ulcerative colitis having precancerous lesions. We are still under prophylaxis and early diagnosis. So we have talked about who and when we make coloscopy, for whom and when. And now we are talking about the aims or the goals of screening coloscopy. What are we aiming for during the coloscopy, or what are our goals? So sure, we are looking for adenomas and in order to prevent an interval cancer. Interval cancer is a cancer that's diagnosed after an unremarkable screening coloscopy within the monitoring period. That's mostly between 5 to 10 years. And the main factor here is the adenoma detection rate. So our goal is an adenoma detection rate of 20% at least. So that we could avoid an interval cancer, we need at least a 20% adenoma detection rate. There are also nowadays artificial intelligence supported coloscopy. It's now growing in Germany, but it's not 100% reliable. It helps detecting, but that could never replace a very experienced examiner. Every increase in adenoma detection rate by 1% help decreasing the risk of interval cancer by 3% and the risk of fatal interval cancer by 5%. Differentiation of the lesions, that's the histopathological differentiation, whether they are hyperplastic, adenomatous, submucosal, or invasive. That's the other goal. And according to the histopathological differentiation of the adenomas or the polyps, we could determine the further management. Also, R0 resection of early carcinomas or the RX-R1 resection together with a negative control in 2 till 6 months, according to the pathology. So the pathology doctors should tell us whether we have what type of tumor polyp or adenoma we have, and whether we have an R0 resection or an RX or R1 resection, or also a free margin. So the examiner should tell in the coloscopy setting how the tumor or how the adenoma, how does it look like. And the best or the most common used subclassification, morphological subclassification of polyps or adenomas is the Paris classification. Here we classify the polyps according to the morphology in coloscopy, whether they are protruded, pedunculated, protruded, sessile, superficial, elevated, flat, superficial, shallow, or depressed or excavated. So we have a malignant polyp. When are we operating? When to operate that malignant polyp? We have seen a polyp. We have extracted it or we have excised it in the coloscopy, and the pathology doctor told us it is a malignant or a pre-malignant lesion. When could we say, okay, that it's okay, we have removed it in the endoscopy, we need no surgery, or when we say surgery? There are also a couple of classifications that could help us.
Hallo, Dr.
So the relative low risk polyps or adenomas are the grade 1, grade 2 adenomas with L0, V0. That means no lymph and no vascular infiltration, and R0 with a free margin more than 2 millimeter, and also polyps which are less than 3 centimeter in the rectum, and also they should be hanged till 3, yeah, and Kikuchi SM1 or 2, and the depth of infiltration should be less than 1 millimeter. If we have those factors, morphological and pathological, so we only need a follow-up coloscopy, and the other tumors with higher grades of dysplasia or lymph infiltration and vascular infiltration and RX status, excision status, and free margin less than 1 millimeter, and grow bigger than 3 centimeter in rectum, having a Haggett or Kikuchi stage, Haggett fear and of 4 and Kikuchi of 3, and depth more than 1 millimeter, they should be operated, or the surgeon should decide whether the patient should be operated, or they should be maybe more intensively follow-up in follow-up programs. So the follow-up intervals are mainly depending on the number of adenomas in the coloscopy and how big are the adenomas, and which pathological type do they have, or which pathological subtype, or whether villous or tubulovillous. We have said, as we've said before, the villous and tubulovillous are the more evil lesions, and that's why we should follow up more closely and more oftenly. When the adenoma is more than 10 millimeter or 1 centimeter, they should be followed up or controlled more frequently. So we have diagnosed the colon cancer. How could we stage it? In a case of rectum carcinoma, it's important to decide the T status. T status could be precisely detected in an MRI or an endosonography to tell the depth of the infiltration. The N status could be roughly shown in a CT of abdomen, but the most precise way to detect the N status is the postoperative PN status. And very important for surgeons, we have to excise minimally 12 lymph nodes in intraoperative. M status, mostly CT, thorax and abdomen, should tell us there is no indication for PET-CT. Laparoscopy and paracentesis in the case of ascites, or in the case where we think the patient could have a peritoneal carcinoma. Tumor marker is mainly a CAA. CA 19.9 is not indicated. So we are talking here about the first diagnosis. Most of us really, mainly in Egypt, may see like most of the cases could unfortunately get a PET-CT, which is not indicated, or maybe a tumor marker at the first diagnosis of CA 19.9, which is also not indicated. The treatment of colon cancer, as we see, that's a very, very big topic. So we are concentrating here at the treatment of early stages, the treatment of metastatic stages, or the stage 4. Should be discussed in another setting. So stage 1 to 3. Stage 1 is clear, actually operation and then follow up according to the S3 guidelines. And stage 2 and 3. The determinants in stage 2 and 3 are the risk factors. Yeah. What are the risk factors that we should know by the patients of stage 2 and 3? T4 stage, tumor perforation, intraoperative tumor tear, and operation under emergency conditions, like in the case of ileus. When the patient comes with an acute ileus in the emergency room, and he would be in an emergency condition, he would be operated in an emergency condition that's actually inoptimal for the diagnosis, and it's not like an elective operation for a tumor where the operator really knows he should excise 12 lymph nodes and so on. Histopathologically documented L1 or V1 status, so lymph or blood vessel infiltration. So those are the risk factors. So we could divide the stage 2 patients in stage 2 with risk factors or without risk factors. The stage 2 patients
with risk factors should receive 5-FU glycovine or capecitabine for 6 months. That's a recommendation of grade B with evidence of 3B. Stage 2 patients without risk factors. Yeah, they in this field, that's a gray zone, as we call it. It's debatable whether follow-up or 5-FU. Maybe the age could tell us more, the fitness of the patient and the willingness of the patient to get chemotherapy, and also the MSI status, microsatellite instability status could tell us, because the stage 2 patients without risk factors with MSI instability, they are recommended to get only a follow-up. And that's a grade B recommendation with 2A evidence, which is actually let's say a supported evidence-supported recommendation. Stage 3. The main question in stage 3, how long we treat the patients, 3 months, 6 months. The MOSAIC study have showed us that oxaliplatin is significant for the treatment of stage 3 patients. So we are talking about FOLFOX therapy, or CAP-OX, capecitabine oxaliplatin, or 5-FU glycovine and oxaliplatin. Here in Germany, in the guidelines, the age should be also a determinant, but the biological age. So we say if the patient is like 75 but as fit as a 65 or a year-old patient, so he should be classified as a biological age less than 70 years. Those patients get mainly 5-FU oxaliplatin, and the patients over 70-year biological age, they get 5-FU or capecitabine, mainly capecitabine for 6 months. But we have also the IDEA study. The IDEA study tells us, according to the risk groups, also the risk factors, like low risk groups are groups with T1 till 3 and N1 status. They should mainly receive a CAP-OX regimen for 3 months. And the high-risk groups should mainly receive 3 to 6 months CAP-OX. The IDEA study have shown us that is actually there is no big difference between 3 and 6 months treatment. Not a big difference, but there's like 1 to 3% of difference between 3 and 6 months of treatment, and that's why we are marking here the 6 months with a red, it's like when it's compared to the polyneuropathy and side effects which the patient gets, and the diarrhea and mucositis, the side effects which the patient gets is not actually recommended for patient to get. Mainly the old patient, the multimorbid patients with diabetes, with already known or already peripheral neuropathy existing, we should avoid giving FOLFOX for 6 months, and we should consider CAPOX for 3 to 6 months. Yeah, exactly. Also another determining factors for the prognosis are the TNM, actually the TNM staging clear, immune score, that's a score of quantification of CD3 and CD8 positive T cells in tumor center and on the invasion margin. The score varies from I0 to I4. That tells us a lot about the prognosis. The ctDNA is also an important factor. That's an immunohistological factor. And the CMS stage is also, as we talked before, is also important for the prognosis. So, as we already said, in stage 3, we should be more patient-oriented, yeah, that's the interesting thing in the treatment of colorectal cancer, because yeah, we have guidelines, but the guidelines are also relatively flexible, and we are also treating patients, and there are also gray zones in the treatment of colon cancer where the oncologists need a lot of experience and also need to be more patient-oriented to determine the therapy. Important notices for the treatment of colorectal cancer. It's becoming it's becoming a standard in Germany that we determine that DPD deficiency before starting 5-FU. Patients with high-grade DPD deficiency would get or would be more susceptible to extreme adverse effects from 5-FU. When talking about adverse effects of 5-FU, we are talking about the diarrhea, mucositis, and we are talking about and when we are talking about the adverse effects of oxaliplatin, we are talking about the neurotoxicity. So patients with diabetes mellitus and existing polyneuropathy should be considered before oxaliplatin. Those factors could tell us how we also determine the doses of the therapy when we decide for a 5-FU therapy for a patient with a DPD deficiency. That also could be quantified in percentage, how deficient is the patient, and according to the quantification, we could also determine the doses of 5-FU. And also patients with existing polyneuropathy should get a doses reduction of oxaliplatin. And yeah, I have also once seen a patient with a very therapy resistant skin changes, like he have got a skin rash, and he have got a DPD deficiency, which actually a little bit late discovered under 5FU. And we don't also we have not to forget that 5FU patients could get acute coronary syndrome or angina pectoris under the therapy. We should exclude acute myocardial infarct for those patients on the in the oncology department with angina pectoris symptoms and having 5FU for 24 hours or for 48 hours. We should exclude myocardial infarct. So I thank you very much for the attendance, and I hope it was an informative session. Those are the references, and I thank you all, and specifically my mentor, Professor Dr. Khalid Sayad, for involving me in the GESR community. Thank you.